morning. So today we will continue the discussion what we had done yesterday. We discussed regarding how to assess dehydration in a child. Now the question comes, how will you manage this dehydration? So as you are aware, you can have classified your dehydration into, there are different methods. You can one method, simple thing can be mild, moderate and severe dehydration. See, this severe dehydration category, the patient can have associated hypotension also. Okay, so in these two things, mild and moderate, there might not be any hypotension. So in when there is severe dehydration, the child can go into hypotension also. So all this dehydration doesn't mean that the child is having dehydration. The child is having hypotension. So dehydration means there is loss of water and electrolytes from the body. That's the only thing. But some dehydration, the child can go into hypotension also. So usually it will be seen in severe dehydration. So the treatment approach, as I told yesterday, whatever be the type of dehydration, the treatment approach will be simple. These things that you need to remember: one, status of dehydration, or you can remember volume status. So volume status, what I mean is whether the patient is having hypotension or normal blood pressure or just simple dehydration. So these are the things that what I anticipate here. And second one is you have to see what is the underlying cardiac status of the child. So in adult patient is very important because they will have associated LV dysfunction also. But in children, to have a cardiac dysfunction is rare, but still they can have underlying cardiac problem. So when you have an underlying cardiac issue, if you are pumping more and more fluids, what is going to happen? The child is going to develop a pulmonary edema. So you need to know the cardiac status. Quickly you can assess the cardiac status by auscultating and by taking a quick history, whether the child has got any previous heart surgeries or the child is on any diuretics. The child is already on some diuretics, that is a clue that the child is having a heart failure. So these are the clues by which you can say that okay, this child is not having or having. So simple things you can remember and see whether what is the cardiac status of the child. And third thing is that whether the child is able to take oral or IV. So the decision will be whether we have to give oral fluids or IV fluids. So as I told yesterday, what are the indications for IV? So IV indications are: one, severe dehydration where you need huge amount of fluid to be replaced. So that is a time when you want a large quantity of fluid that need to be replaced. Not able to take orally because the child have continuous vomiting or the child is severely drowsy. So that is a situation where you cannot give orally. Not able to take orally, or situation you will not be able to give oral feed to the child. And third thing will be you want to correct a lot of electrolytes also. So suppose there is a huge diarrhea, the child is having multiple episodes of diarrhea, there will be decrease in sodium, there will be decrease in potassium and other electrolytes also. So you need to replace that. So sometimes you need replacement will not be sufficient to be given orally. But those situations, if the child has got significant hyponatremia and hypokalemia, you need to have IV corrections also. So these are the situations where you want to give IV over oral. So situation number one, where the child is not able to take oral feeds, you need to give IV. Situation number two, the child is having severe hypotension where you want to give large amount of volume of water, you definitely need to give that. And third thing is that you wanted to give other electrolytes that need to be replaced, which cannot be given orally also to be replaced. So this is the nutshell where you wanted to give IV as well as oral. So if the patient is able to take orally, the safest and the simplest formula what you can remember is you can give oral rehydration solution. So there is commercially available preparation also. You can just take 1 liter of water and you can boil it, and one packet you can mix it and you can give to the child. So if the child had one episode of loose stools, soon after the loose stool you give around 50 to 100 ml of this oral dehydration solution. So that is a simple formula that you can remember. The child is able to take orally, the child is having quite thirsty, you make an oral dehydration solution. So don't use it more than 24 hours. Whatever fluids that you have prepared, you have to discard it after 24 hours. So you have prepared it, you have to use it within 24 hours. So you prepare it and you give to the child. After every loose stools, you give 50 to 100 ml to the child, depending upon the age. The child is very small, 50 ml should be enough. The child is like more than 2 years, like 4 years, 6 years, maybe 100 to 150 ml is needed, depending upon the age of the child that you need to decide. So that's a simple thing that you can give oral dehydration solution. Suppose you don't have a remote setting where a commercially available preparation is not available, you can make simple things in homemade ORS. Homemade ORS, we can all make these things. What does ORS basically contain? ORS contains basically, it will have lot of, one thing, 1 liter of water we are adding, right? So there is a lot of fluid and it contains major products will be sodium, potassium and minor electrolytes, and also it will have some amount of glucose. So that energy part also will be taken care. So what is homemade ORS? Homemade ORS is pretty simple. You take 1 liter of water, you how much salt do you need to add? You need to add 1 pinch of salt and 1 tablespoon of sugar, and you mix it and give to the child. So the same thing, that is a simple thing you can make in homemade ORS. So again, this homemade ORS should be given for a time frame of 24 hours only, not more than 24 hours. So the child is able to take orally, you want to give oral dehydration solutions. So just minimal and moderate dehydrations will be corrected by this. But one more thing that you need to remember is that when you go to a patient with severe dehydration, okay, so you want to remember and understand that total body water in our body around 0.6 percentage is water. So 0.6, that is 6%, 60% is water. After 1.6 is water. So suppose there is a 10% of fluid loss. 10% of fluid loss in the body. So how much ml of water will be lost? See, 10% of fluid loss. So that will be approximately for a 10 kg child. You calculate for a 10 kg child. For 10 kg child, it will be in 10 kg into 0.6. So that is approximately 6 liters of water is there. And from this 6 liters, I am telling 10% has gone. So how much ml would have gone? 600, 10%, 600 ml of fluid would have been lost. So that is the amount of fluid that is lost from the body. So see, the body will try in a child, the body will try to compensate until there is a 40% of fluid loss from the body. So suppose you imagine, that is why I wanted to tell you. So the body will try to compensate up till in a child up to 40% of the water loss. The 40% of the fluid loss is happened, then only the child will go into hypotension. So till that time, the body will compensate. So the body will compensate. So what will happen? There will not be any hypotension. So if hypotension occurs, it is called as decompensated shock, or you can call it as hypotensive shock. You understood? So the body will try to compensate below 40%. So suppose there is 20% of fluid loss in the body will try to compensate in a such a way that only the peripheral circulation or there is capillary perfusion is only getting affected. The main organs perfusion is maintained and there is no hypotension. So that is called as compensated shock. Already the body has compensated for that. And if the patient have more than 40%, it is going into hypotension. So it is called as hypotensive shock. Pretty simple. The other one, the body has compensated, but there is shock. So shock doesn't mean hypotension. I always say shock and hypotensions are not synonyms. Shock is the situation of the cell where is decreased perfusion. So even without hypotension, you can have shock. So in a situation where for example, you are seeing a patient, his BP is 90/60, but his capillary refilling time is more than 2 seconds. So what does that mean? There is no hypotension, but there is poor perfusion to the periphery. So that means that patient is in shock. So you have to understand whether it is a compensated shock or whether it is an hypotensive shock. So these are the two terminologies that you need to use. Suppose there is associated hypotension, we will call it as hypotensive shock, or you can call it as decompensated shock, or on the other side, if there is no hypotension but there is evidence of shock, we can call it as compensated shock. So these are the two terminologies that you can remember. Why I am telling you this? See, for a child with severe dehydration, we have three major problems. One, already there is hypotension. So we need to treat this hypotension. Second one, there is an ongoing loss. See, the child is already having diarrhea. So there is already having ongoing loss. And third one, there is a basic requirement as called as maintenance fluid. That is a basic requirement for every child, irrespective of the type of shock, a maintenance fluid is the basic requirement of fluid what is needed to a child. So the third one is the maintenance fluid. So fluid selection for these three things should be different. So when you want to treat hypotension, you want to treat the ongoing loss, you want to treat a maintenance fluid also. So maintenance fluid is the one that should give you the energy and basic required electrolytes, what is needed for a normal child. But here the child is having much more deficiency. There are a lot of other deficiency. So that also we need to replace. So our idea is here, first you need to treat the hypotension. So hypotension you will treat with by giving boluses, and whatever there is an ongoing loss, the child is already having multiple episodes of diarrhea or loose stools, we need to replace that also, and also we need to give a maintenance fluid. So the total fluid required will depend upon what is the type of dehydration that is the child is having. So for a normal child, what you have to do, where there is only very minimal dehydration, what you have to do, maintenance fluid the child will take, and on top of that you need to give them additional fluid loss, whatever has happened, additional fluid whatever has happened as loss. That is what you need to give for those type. For a child with severe dehydration, there is associated hypotension also. If there is hypotension, you need to correct that hypotension first, then only the tissue perfusion will improve. Then there is already an ongoing loss, we need to correct that ongoing loss, and also we need to give a maintenance fluid. So these three things you need to tackle. So how will you tackle this thing? So hypotension, as you know, as in for any patient with dehydration, the fluid of choice is isotonic crystalloids. So you can either give a ringer lactate, normal saline, or plasmolate. Whatever be this, you can give a balanced fluid. Isotonic crystalloids are the option. So you can start with something like 20 ml per kg as a fluid bolus, and depending upon the patient's response, you can go upon multiple boluses. Maybe till 20 ml we can give 2 or 3 time boluses, depending upon how the child is responding to your fluid therapy. So that is first thing, you can choose either your isotonic crystalloids, normal saline, ringer lactate, or plasmolate. So these are the fluid of choices that you need to take in. So that is for your hypotension. So see here, hypotension, one more thing, if the child has got a cardiac issue, you are not very sure the child is having a cardiac issue, the child will go. So we have a doubt, then in mind, don't go for 10 ml, 20 ml per kg. You start with somewhere around 5 to 10 ml per kg. So you start with somewhere around 5 to 10 ml per kg for those group of child where you have a doubt whether this child is having a doubtful cardiac history, cardiac failure possibility is there, you start with 5 to 10 ml per kg. So first thing, we are correcting the hypotension, and next thing what we are doing, next thing, ongoing losses. Whatever be the ongoing losses we have to treat. So ongoing losses, what you can give, you want to give either of this ringer lactate or oral dehydration solution if the child is able to take orally, but it is severe dehydration, the child will not be able to take orally. So the same fluid you can continue as an, either you have to give an ongoing fluid loss, you can either give an electrolyte like normal saline or ringer lactate, or you can give something called as half DNS. Why you want to give half DNS is what? DNS isotonicity will be very high, it will be 5%. So if it is half, the tonicity will come down, and the peripheral line you will be able to give it better. So one thing what we can give is half DNS. So DNS will contain some amount of sodium, some amount of chloride, some amount of glucose, but it don't have potassium. There is an additional potassium deficiency, approximately 2 milligrams per kg is the requirement for potassium. So there is an additional potassium deficiency for a 10 kg child, you can add 20 milligrams KCl to this also. So you can just add 20 milligrams of KCl to this. So one thing we are started, first our idea, correct the hypotension. Once the hypotension is corrected, we have to treat the ongoing loss and maintenance fluid. That you can combine together. So what is the maintenance fluid and how will you calculate the maintenance fluid is the next important question. The pediatrician is coming and telling you, give fluid at 60 ml per hour. How they are coming to that conclusion? That is very important. You should know what is, how to calculate the maintenance fluid loss. So for that, it is a pretty simple formula. For patient with 1 to 10 kg, okay, it is 100 ml per kg is the maintenance fluid that is required for 24 hours. For every increase of 10 to 20 kg, it will be 50 ml per kg you need to add to this. I will tell you, I will give you one example and we'll calculate what is the maintenance fluid that is required, then you will get an idea. For 20 kg and above, for every kg you need to give 20 ml per kg additional. So imagine I am giving a first thing, a child is having 8 kg. So how much amount of fluid is required for the child as the maintenance fluid for the next 24 hours? 8 into 100, that is 800 ml. So this is the 800 ml is the amount of fluid that child is required as maintenance fluid for the next 24 hours. So 800 divided by 24, if you do that, that much ml you need to give it in an hour. That is how we are coming to a conclusion. Clear? So that is for an 8 kg child. Now we will do for a 15 kg child. Okay, 15 kg child. So 15 kg child. So the first 10 kg it is 100 ml per kg. So it is 1000 ml, right? So for the next 5 kgs, 5 into 50. So plus 250. So 1250 ml you need to give in 24 hours. So that is the maintenance fluid that is required for that child. Next we will take a child for 24 kg. So first 10 kg 1000 ml, next 10 kg 500 ml. Then for every 1 kg increase you need to add 20 ml. So 4 kg increase, 4 into 20 80. So 80. So 1580 ml that you need to give it over 24 hours. Clear? Clear? Is it clear for you? So the first 10 kg 100 ml per kg, for the next 10 to 20 kg 50 ml per kg, from above 20 kg you add 20 ml per kg. So this is called as Holiday-Segar formula. Holiday, what will I write? Okay, here. Holiday-Segar formula. Pretty simple formula. So our idea is to, this is the, what is the fluid, what is we have calculated, this is the maintenance fluid that is required. So maintenance fluid, the child is able to take orally, you can give it orally, but if the child is unable to take orally, you have to give IV. So when you want to give us an IV, what all fluids you need to calculate? You need to calculate the maintenance fluid as well as whatever be the ongoing loss, and also you need to correct the hypotension which has happened for a child with severe dehydration. So that part you have to be very clear. So that is the fluid that you need to calculate, and again maintenance fluid can be an ideal fluid of choice. There is something called as isolate P. You have seen that fluid. Isolate P is specifically designed for pediatric. It's an isotonic solution, again specifically designed for pediatric age group. So isolate P is one fluid that you can use. Then again, if you are not able to give, your fluid should have basic requirement. There should be fluid, there should be electrolytes, especially sodium, potassium, and you should have dextrose also. So if there is any deficiency of any of these electrolytes, suppose the potassium is low, you can add potassium to it. So that is how we will calculate. So suppose 1580 divided by 24, that much ml you need to give, plus ongoing loss you need to add, plus hypotension is there, you need to give boluses also. So that is how you need to calculate the maintenance fluid. So clear? Maintenance fluid calculation. So for an, I'll give you an example. You just calculate, every one of you calculate 32 kg child, 32 kg child, how much fluid you need to give? 32 kg, you calculate the maintenance fluid. So first 10 kg 1000 ml, next is 500 ml, next 10 kg 20 ml per kg. 12 into 20, how much is it? 240. So 240. So total 1740. this should be the total fluid as been given as maintenance fluid over 24 hours. That part has to be clear. Over 24 hours. So this is the amount of fluid that you need to give over 24 hours. You just calculate 1740 divided by 24. That will be the ml per hour that you will get. So 1740 divided by 24, that much ml you need to give a SN per hour. So basically dehydration, you need to understand is that what is the type of dehydration the child is having. When after knowing the type of dehydration, next important thing is that whether the child is able to take oral or whether the child is taking IV. Word to give IV, I have already said, and how to calculate the fluid. So we need to treat the hypotension, there is associated hypotension. We need to treat that severe dehydration, the ongoing losses, severe dehydration, plus you need to treat the maintenance fluid also. So these are the things that you need to remember. Okay, thank you.